telescope into the abdominal cavity, having put some gas inside at the time of laparoscopy, we also have an instrument inside the womb that lifts the womb upwards, so that when we now look with our telescope in this direction, we can see the back of the womb here. We can see the right fallopian tube, the right ovary, the left fallopian tube, the left ovary, the round ligaments which help to support the womb, and behind the uterosacral ligaments here, which also help to support the womb. The fallopian tubes are very clearly seen, and the bowel goes behind the womb into the pouch of Douglas and down towards the rectum. And this is the lowest space in the peritoneal cavity. So when we see endometriosis, we see it in a number of different areas. First of all, the most common place we see it is here on the uterosacral ligaments. We may see it in this area. Now this area is very highly supplied with nerves, particularly just lateral to the uterosacral ligament here and underneath the ovary. And this is what we would call stage 1 or stage 2 endometriosis. If it gets a little bit more severe, then what we see is endometriosis in the ovary itself, and we call this an endometrioma. And we may see endometrioma like this, taking over much of the ovary, with the ovary stretched around it, so that we have a normal rim of ovary around the edge of this endometrioma. If the endometriosis is even worse, we may see an endometrioma on the other ovary. And in fact, it may be large enough that these two are seen to be touching in the midline. And we call this kissing ovaries. Again, there will normally be a bit of ovary stretched around the edge of this endometriotic cyst. We're now talking about stage 4 disease. And what we also see with this is a lot of adhesions. These ovaries are stuck onto the back of the womb here. They're stuck very firmly together in the midline, and they're stuck to the pelvic sidewall and the fallopian tubes, like this. And you can see the fallopian tubes themselves become buried. If the situation gets even worse, then what we see at that point is that the bowel is also stuck onto the back of the womb. Now, it's not this lower part of the bowel initially, it's this transverse colon here, which is swung forwards and stuck onto the back of the womb, so that what we see is this loop coming up like so, and like so. Now, at this point, we've got a loop of bowel stuck onto the back of the womb, like this. And this is stuck in front of the ovaries and the fallopian tubes. So you can see how difficult and distorted the anatomy becomes. When we put our telescope in cases such as this, all we see are these adhesions here of the bowel to the top of the womb. Both ovaries, fallopian tubes, and all the normal anatomy are obscured. This is stage 4 disease. And just to make things even worse, what can happen is that as the bowel descends behind the womb, it also gets hitched up onto the back of the womb like this, underneath here as well. So having dissected off the bowel higher up here, freed up the ovaries, we're then faced with bowel that's stuck deep in the pouch of Douglas. And this is particularly dangerous because in this area we also have the ureters, which are coming down from the kidneys up here and coming down behind the bowel, all the way here, behind the ovary, and then go forward just either side of the uterosacral ligaments. So when we have this type of endometriosis, not only do we need to worry about damaging the bowel at this point, we then have to be careful about not damaging the ovaries and separating them away from the bowel and the fallopian tubes. Having done this, we then have the great difficulty of separating the bowel off the back of the womb and the pelvic side wall without damaging the ovaries. And of course, this is what we try to achieve. So first of all, we take away the adhesions of the bowel. Then we try to free the bowel off the back of the womb. Having done this, we're then left being able to visualize the ovaries. We try to take away the adhesions between the ovary and the womb to separate this off and to drain the endometriosis. We do this on both sides. We try very hard to separate all of this and then drain the endometriosis from both ovaries and try to strip it out. Try to free up the endometriosis behind the womb and to dissect off all of the bowel. We're then left with this very difficult area here where the bowel is stuck in relation to, in particular, the left ovary, the left ureter, and the back of the womb. And this is the most difficult area in many cases that we come across in endometriosis. What we try to do is to open up this space next to the large bowel on the right-hand side, here in this area here, medial to the ureter, the right paracolic gutter. We then try to get in at this point, open up the peritoneum, find the ureter, and again dissect in the paracolic gutter, try to push the bowel towards the middle, and then dissect it off the back of the womb. So eventually we are completely clear in all these areas. Of course, what we're left with is not a pelvis that looks like this, but one that is quite badly inflamed, so that this whole area here is rather reddened and inflamed and bloody around these ovaries. And we cannot always be sure that we've removed all of the endometriosis, because indeed there might be some small deposits in this area that are left. So what we do at this point is to place an adhesion prevention mesh over the top of this that dissolves in a period of about 10 days. We would then treat with gonapeptyl, which is an LHRH analog or an artificial temporary menopause, to switch off any remaining deposits of endometriosis that there might be around the place, and also to help to reduce the blood flow to this area. We'll then come back after 6 months, reoperate, divide any adhesions that may have formed around the ovaries, perhaps where the ovaries are stuck, free up the fallopian tubes, free up the bowel a little bit further, and then at that point, hopefully, we manage to achieve something that looks more like the normal pelvis again. Although, of course, there may still be some scarring around the fallopian tubes on either side that might still restrict fertility. We can hopefully achieve a much more normal anatomical result. And this is the basis of the type of surgery that we try to perform. What we try to do is to excise all of the abnormal areas of endometriosis within this part of the pelvis. It's not necessary to excise the peritoneum here and here, or here and here, but this area here behind the womb needs to be excised. We leave the ovaries behind. We do not remove them. We do not remove the fallopian tubes. These are essential for future fertility. If the appendix is involved, we separate that away, because again, this can become inflamed and cause appendicitis. So what we're doing all the time is trying to excise the endometriosis, trying to normalize the pelvis without removing any of the essential structures which are necessary for for women's future reproductive careers. And we feel that with this very much planned, combined approach, we can achieve really good results. And what we then need to do, perhaps at the end, having achieved this after 8 months of input for both the surgeon and the patient, is to place then a Mirena coil inside the womb. This releases progesterone continuously and helps to prevent any future endometriosis by preventing periods, preventing any more retrograde menstruation, depositing endometriosis into the pouch of Douglas. We get excellent results with this, and this allows women then to take their time, to get over their endometriosis and plan the next step, which is usually trying to have a family. I hope you found this video useful.